everyone. Good afternoon. Thank you for joining us. My name is Morgan Gargiulo from the New England QIN-QIO, and we want to thank you for joining us for today's webinar as we review the December 2015 NHSN newsletter. Before we get started, I'm going to go over a few housekeeping items. This call is being recorded for training purposes. I will provide you with details on accessing the recording at the end of the webinar. The phone lines are on mute for the duration of the presentation. We will be taking questions throughout, and we'll provide you with instructions at that time how to unmute your lines. So for now, I'm going to pass it over to Carol Dietz to get us started.
Good afternoon, everyone. Welcome and Happy New Year. Can't believe it's almost February 2016. For the next 45 minutes or so, several of the HAI team members from the New England QIN-QIO will be reviewing the most current NHSN newsletter that came out in December of 2015. The reason why we have decided to do this, as we traveled around the 6 New England states and talked with the different hospital infection preventionists, we have heard that most infection preventionists absolutely feel this is a valuable resource, this NHSN newsletter. They print it down or they save it to their desktop. They put it on the priorities list to read it, to absorb it, and somehow it gets moved down to the bottom of the list by the end of the week, and yet we have heard that they never get around to actually reviewing it. So we have decided to provide this as a resource for you so we can learn together what NHSN has updates in and what they want to make sure you're focusing your data on. So I want to make it clear that we are not NHSN staff members. We are just providing this as a resource so we can all review it together in a very succinct manner, and then you can go on with the rest of your day. The other thing is we are doing a high-level review. We're not going to be doing a deep dive into each of the sections, especially when it comes to the changes in the surveillance sections, because NHSN will be providing an in-depth training at the end of February through the first week in March at the CDC on all the changes that have been put in place for 2016. And we're going to be talking about that as we review the NHSN newsletter. We want this session to be as interactive as possible. So as Morgan mentioned, we have a couple of stop pauses in the middle of our presentations for questions. We have a staff member, Morgan, who's watching our chat box. So as we are talking and as we're reviewing different sections, if you have a question, please go ahead and put them in the chat box, and we'll address them as the sessions go on. We really want to treat this like a fireside chat. We're all in this together. We all need this resource, this really important NHSN newsletter, so that's why we at the New England QIN-QIO decided to go ahead and put this webinar together. As we always do, I just want to make sure for those new infection preventionists or the new quality directors who are listening, who the New England QIN-QIO is. We are the Quality Innovative Network Quality Improvement Organization that we are working for CMS under the scope of work contract. Health-Centric Advisors is the lead QIO, and they have partnered with Qualidyne to form the New England QIN-QIO, so all 6 states by the New England QIN-QIO. And the goal is to provide you resources and technical assistance to reduce, in this task, to reduce the HAIs within your hospitals, your CLEXIs, your CAUDIs, your CDIs. We're also going to be looking at VAE starting this year, the ventilator-associated infections. But the goal of the entire work we're doing is to create the healthiest region in the United States. And hopefully we're on our way. With that being said, I just wanted to make sure that everyone who is listening is aware that each state is covered with an HAI task lead, and this is our contact information. As I mentioned, I am Carol Dietz from Connecticut, and Denise Selfridge, who will be next online, are the the HAI state lead from Massachusetts. Danielle Hersey is the state HAI task lead as well as the state director from Maine. Margaret Crowley is the state HAI task lead from New Hampshire as well as the state director. Maureen Masella, who is, everyone knows her in Rhode Island. She has been with the QIN-QIO for quite some time, but she is the HAI lead for Rhode Island. And Regina Ann Cooper is the HAI state task lead from Vermont. And they're all on board and listening as we are carrying on. So let's get into the work that we're here to do today. The objectives of today: identify changes to the patient safety module impacting accurate NHSN reporting for acute care hospitals in 2016 by reviewing the most current NHSN newsletter, and also list acute care hospital data submission deadlines for CMS reporting in NHSN, because there's a deadline right around the corner. We want to make sure everyone is aware of it, as well as the data that needs to be submitted into NHSN. So this is the table of contents of the newsletter. So hopefully as you logged on to listen to this webinar, you saw that we had sent you out a newsletter, the NHSN December newsletter. We also sent you out the slides. We also sent you out the NHSN manual update, the January 2016 release. And then we also sent you the inpatient rehab facility locations mapping that I will be referring to later on in this presentation. So hopefully you received all 4 of those documents.
I did put the link in chat if people can get that.
Great, and Morgan just mentioned that she did put the link in chat to make sure that you can get all these documents if you haven't downloaded them right up to this point. So, okay, so this is the table of contents. As I mentioned, we're going to really focus on the patient safety component, but we are going to address all the other items on the table of contents. So I'm going to start with the very first box that's on page 2 of the NHSN newsletter. And this was all about the January 9th, 2016 release that they had asked you do not put any 2016 data into NHSN until the release has taken place, and it has taken place. It happened on January 9th. So now you can go ahead and put all your most current data, your 2016 data, into NHSN, as well as you can pull down your annual report, annual survey, which Denise is going to talk about in a little bit. But this box was one of those, the update's coming, the release is coming, just hold off. And now that it's January 26, 2016, the release is done, and the NHSN database is open for your 2016 data. So for the next couple of sessions, I'm going to turn it over to Denise Selfridge, who, as I mentioned, is the HAI task lead from Massachusetts. Denise, the mic is yours.
Hello, everybody. Can you hear me?
Yes, we can.
Oh, good that I did it right. Okay, what I'm going to do is I'm going to talk to you, and I'm going to identify the page that I'm talking off of so that you can keep track on the newsletter. The first that I'm going to talk about is the section for 2016 NHSN Patient Safety Component Protocol Release. This is the manual that everybody needs to have access to. And there's a link in this box right here that will bring you right to the patient safety protocols. I suggest that you download it and keep it someplace on your own personal computer, because for some reason they tend to pull it off for updates and then it disappears, goes MIA from us. It's a possibility. So it's an important thing to have. So if you want to take the time to save it to your computer, that would be a great idea. And the next thing on page 2 is the CAUTI data entry updates. People noticed last year when they were entering infections related to an indwelling Foley that they couldn't select specific symptoms, and they had to do a workaround for that. So now, if you are selected in-dwelling fully, you will be able to elect for symptoms, frequency, dysuria, and there was probably one other one. So there's no need for the workaround that you needed to do in the past. So then we go to page 3, and we're going to talk about the MDRO CDI Lab ID event reporting update. There's 2 new questions that are requested to be answered. One is the last physical overnight location of the patient immediately arriving to the facility, and the other is, has this patient been discharged from any facility in the past 4 weeks? And you have a range of answers, and you do have the opportunity to elect unknown, but their request is that you don't select unknown unless you absolutely have to. The idea is that they're going to be able to better track CDI infections within the community by looking at this data as it grows. So if you have the opportunity to find out where the last physical location was, or if they've been in another facility within the past 4 weeks, then that would be very beneficial to data quality going down the road. And the next section is ICD-10s and CPT codes. There's 2 links here on page 3 so that you can find the updates and the mappings for those. These are reports that you've relied on the ICD-9s to get your information to upload your SSI denominator data, and there is a change that it will not accept specific formats as of the update. So you need to have your IT people look at your reports that you're using to upload your CSV files and your CDA files and make sure that they're current for the way the uploads go right now. And then on the next page, page 5, everyone that I've talked to has been waiting for this HAI President of Mission Worksheet Generator. And unfortunately, there's still some problems with that, and this is going to be delayed for an unknown period of time, but they will identify, NHSN will send out information when that's available. And pretty much what this did is you could put that information in and generate a worksheet so you could decide whether it was present, whether the infection was present on admission or not. So we're waiting to see when that's released. So again on page 5, we're going to talk about the Patient Safety Annual Facility Survey. It's pretty much the same as it has been in years past, but the important thing to know is that it needs to be completed by March 1st. And if it's not completed, you won't be able to do your reporting plans for the rest of the year. So if you have any questions about doing that, there's a link on page 5 for a tutorial, about 10-15 minutes long, on how to complete the survey. And then we go on to page 6, and this is where it gets a little bit interesting. CAUTI SIRS are going to be a new baseline. This is going to be a baseline year that we just passed, 2015. The interesting part about that is there was changes in the definitions of what a UTI was, with the removal of a few elements, no fungal, no yeast, anything like that was removed. So I don't know how much that would have changed it, the SIRS on their own. But in history, the SIRS were built off of ICUs. And in 2015, they've included the non-ICUs in what they've put out so far is information as to how the nation is doing. It was a big surprise to me to see that quarter 1 and quarter 2 of 2015 is currently reporting out at 0.55, where the CAUTI SIR was a little bit over 1 going out of last year. So it would be really important when you're looking at your historical data and your current data that you make this delineation that you either look at your ICUs against your ICUs or your non-ICUs by themselves, or you put them together. But know when you're talking this data in your facility what it's comprised of. And then the next section is for running TAP reports. I know a lot of you have been able to do the TAP reports and find them very, very, very helpful. What NHSN is recommending here is that you take, when you're running the report, before you hit run, go down to the bottom, and there's a section where it has the HHS goals, and they have that preset at 0.75 or 0.775, excuse me. And what you would like to do with that is change that to 0.55 to see if you could get a better understanding of your cumulative attributed, oh my gosh, I can't do that. Your CAD, how's that? Sorry, I can't spell it out for you folks. But it's cumulative attributable difference. Sorry about that. And if you do, that will give you a higher target to reach for reductions where they're currently showing 0.55. That will do 0.55 for your facility as well. And let me see, the updates to the risk adjustment, like I said, 2015 was a baseline year, and CDC is looking at the data, and they plan to be able to readjust the baseline and risk adjustments that will be released probably December 16th or January 17th. And again, really pay attention to the cloudy rates as well as the collapsed rates, because collapsed also moved out of the ICU into non-ICUs as well. So it bears paying attention to. And I think we go to the next slide. Oh, I guess we're looking for questions now.
Thank you, Denise. That was excellent. So this is Carol, back online, and we're going to take a pause right now to see if there's any questions about the different sections we've just covered. To ask a question, you just have to hit #6 to unmute your line, or you can always put it in the chat box, and Morgan is keeping track of the chat box for us. So I'm going to sit on my hands for a few minutes because dead air space always gets me nervous. But I have learned that some people need time to formulate a question in their head. So if anybody has a question, just hit #6 to unmute your line. Okay, since we're having a quiet moment, we're going to continue. We're going to move on. So, our next speaker is, as I introduced her earlier, is Margaret Crowley from New Hampshire. Margaret, the microphone is yours.
Thank you. I'm hoping that everyone can hear me. I'm going to talk about page 8 of your newsletter at the top, which is really focused on changes in VAE analysis. And we're specifically talking about rate analysis and the data set that's used and the output that comes from that. Just a reminder that we know in the past year that the types of VAE were recalibrated into a hierarchy of 3. So starting with the VAC or the ventilator-associated condition, the IVAC, again, in order to meet IVAC, you would have had to have met the criteria for VAC and then moved on to additional criteria to meet the IVAC. And then finally, possible ventilator-associated pneumonia, or PVAC, would have been, again, meeting criteria for VAC, IVAC, and then specific criteria for pneumonia. With the release of the NHSN updates for 2016, we were able to generate some new comparison data, basically looking at generating information that will give you a national pooled mean rate, so that the output that's coming out of NHSN for rates regarding VAE has changed slightly. And the key here is that make sure you look at the titles at the top of each chart, because they will tell you exactly what is included, which specific rates. For example, if it says IVAC plus, it's going to include both the VAC and the IVAC. And if you progress to the next slide, we'll move on. And the second section of page 8 relates to, again, this is kind of a glitch in the clip reporting. And what has happened is if you are reporting clip in acute care hospital outpatient areas or outpatient departments, there was a little glitch in how you enter your data. Typically, you may recall that in almost all the applications, you enter your event type first, then you enter the location, and then you enter the date of insertion. In order to make this application work appropriately for you in these particular areas, OR and the outpatient setting, you actually have to enter your data right after your event type, put in the date of insertion, and then the location, and you'll be all set to go. So that's on, again, page 8. You move on to the next section. This is just a reminder, this is on page 8, that there is a reference guide for acute care hospitals, and there are some additions to that. I have the link here, and it will take you to this section, which is called Frequently Requested Output Reports. And it allows you, this is a change that allows you to go in and create a record of changes that you've made in NHSN reporting. For example, with CMS, you can look at your own data and see when you made modifications. For example, when you first entered an event. So this can be very useful as we accumulate more and more data and changes to the system. If you move on to the next slide, and this slide reflects the information on page 9. This is something that NHSN got a lot of calls about because oftentimes hospitals have to close a unit for one reason or another. They're renovating or they're remodeling, and people were kind of trying to figure out, what do I do with my NHSN location? So there are actually two things that could happen. Maybe that we could come up with others, but these are the two that they recognize. And first is that the location actually moves with all the staff and all the patients to a new location, in which case what you could do is on this location you would change the code and your label values and basically come up with a new location. Another situation that can occur is that the patients can literally, from that unit, be dispersed throughout the hospital. They suggest that you do not close out the old location while it's being renovated. Rather, keep it active and keep it on your monthly reporting plan, but make sure that you're reporting every month that you have no denominated data and no events. And then the patients that have been dispersed will be counted in the data for the particular unit where they're located. So I think that's been a real help to those folks who have had temporarily closed locations. So I'm going to stop here, and I am going to turn it back over, I believe, to Denise. Thanks.
I'm sorry, I was on mute. Okay, I'm going to talk to you about the update in the NHSN antimicrobial use option. This we're not going to spend too much time on because this is an electronically uploaded module to NHSN from your facility. It requires multiple electronic submissions from your lab, from your patient accounts. So this is something that is just so detail-oriented and focused that we're going to block past this and let those facilities that have the total automation that are doing this get their answers straight from NHSN. And there are links built into this section right here if you need to have any kind of information about that. But at this time, it doesn't require anything from the infection preventionist. It's all electronically uploaded. And I think, are we going back to Carol now?
Yes, you are. Thank you, Denise. Okay, so I am on page 11 of the NHSN newsletter. And the first review is, starting on the bottom of page 11, is the new CMS Required Reporting for PPS cancer-exempt hospitals, as well as the new reporting requirements for long-term care hospitals, or the LTACs. So let's first start off with the cancer hospitals. As of January 1st, 2016, these PPS-exempt cancer hospitals must start submitting MRSA, bacteremia, and C. difficile lab ID events by location at the fact-wide inpatient level. Also on the bottom of page 11, for these hospitals, these PPS-exempt cancer hospitals, there is a link for the MDRO protocol, training materials, and data collection form, since it's a brand new requirement for your facility type. And for the LTACs, who are part of the Long-Term Care Hospital Quality Reporting Program, starting on January 1st, you have to start reporting on ventilator-associated events, the VAEs. And it's by location for all adults inpatient. And also on the bottom of this page are links for VAE protocol, the VAE protocol, training materials, and data collection is available. And finally, for everybody, at the bottom of this page, put a big star. That this is something that I would recommend everybody pulling down and either putting it on your desktop or printing it out. There are two links for CMS reporting requirements and deadlines related to NHSN reporting, as well as proposed HAI requirements for all healthcare facilities. These two documents I have literally at my desk by my phone because people are always asking me, are you sure LTACs are supposed to be reporting on VAE, or how about healthcare influenza vaccination status? Who's reporting on those? And these are the two documents that I use all the time because they are truly a resource document. So again, put a big star next to that at the bottom of the page for these two links. All right, on page 12, see, this is where NHSN tries to document all the most current deadlines for all the different type of facilities. So the first discussion is for the acute care hospitals. So your deadline coming up for CMS reporting, required reporting into NHSN is February 15th. I want to let you know that's 2.5 weeks away. So it's right around the corner. So on February 15th, that deadline, your third quarter 2015 HAI data has to be submitted into NHSN. So that's July 1st to September 30th, 2015. And for the acute care hospitals, it's the CLAPC and CLADI data, which includes all the appropriate ICUs, as well as the adult and pediatric medical, surgical, and med-surg wards, plus, I'm not done yet, plus your inpatient colon and hysterectomy SSI data, plus your third quarter 2015 MRSA, bacteremia, and C. difficile lab ID events, which includes all healthcare onset and community onset lab ID events, and it's fact-wide in, plus you're also reporting on your ED and 24-hour observation locations. Now that was a mouthful. Nothing has changed. There has been no updates, so this is what's expected for all acute care hospitals across the nation who are part of the IQR, the Inpatient Quality Reporting Program. And I'm going to give you a tip. And this is something that for the hospitals I work with, I try to get them to put all their most current data in at least 5 days before the deadline. So if you can instead of putting a big star on February 15th on your calendar, put the star on February 10th. just in case there's a glitch in NHSN on February 11th or the 12th, or you win the lottery and you're on the 10th, so you're not going to be there on the 11th. You just want to make sure your hospital's data's in at least 5 days before the deadline. And so if there are any issues, you have that little buffer window to make sure you get in there and make any corrections if necessary. Because once the deadline is over, CMS takes a picture of the database, and you can go in and change your data for NHSN, but not for the CMS deadline. Okay, so that was the acute care hospitals. For the next hospital that's coming up, the PPS Against Cancer Hospital Quality Reporting Program, same deadline, February 15th. And what the data you have to make sure you submit is third quarter 2015. Very similar deadline as the acute care hospital. And the data that you need to be submitting is CLACC and CAUTI data for all embedded inpatient care locations. And also third quarter 2015 inpatient colon and hysterectomy SSI data. So again, no changes here. This was what has been documented in the final rule. And so third quarter 2015 data is due 4.5 months after the close of the quarter, and that's February 15th. Now, as you can tell by this slide, there has been a change. So this is for the inpatient rehab facilities, the IRF. If you have an IRF within your acute care hospital, or if you're a freestanding inpatient rehab facility, please pay attention to this slide. CMS has extended the deadline for reporting the first and second quarter of 2015 of your CAUTI, your MRSA, and your C. difficile lab ID events data to February 15th. So even though you thought you've probably submitted your first and second quarters, you have a chance to go back, look at it, make sure that you're reporting it correctly in NHSN, and then you're going to make sure that by February 15th, your first quarter, second quarter, and third quarter 2015 has been submitted for the February 15th, 2016 deadline. Now, the reason why CMS has done this, has extended this deadline, is because they have found that many of the acute care hospitals that have an inpatient rehab unit within their walls have not reported it out correctly. So that's why I have attached the update to NHSN for IRF locations within acute care hospitals and critical access hospitals. That document was sent out back in 2012, but it is very pertinent because that's when the CAUTI data had to start being reported. But now that it's MRSA and C. diff, it's very pertinent to this deadline. So please, if you do have an IRF within your facility, and you kind of hesitant of whether you're thinking you're doing it correctly or not, please reread this document. I'm going to show you what a monthly reporting plan should look like. Okay, so I couldn't put it all into one slide, so this is the top of the monthly reporting plan. So in front of you, you see that this hospital, this is an acute care hospital, has a NICU, has a surgical unit, has a medical unit, has an ICU, has an oncology unit, orthopedics, and pediatrics. They also have a rehab unit. Now, this unit has a different CCN number. So therefore, you have to go into your location, address it as a new location, put in the CCN number, answer some questions on the annual survey to make sure that it is truly a separate unit. Sort of treat it like a separate facility, even though it's within the walls of the acute care hospital. And now you can see that in this for this hospital, the rehab unit has decided to do CLAPC as well as CODI. The CLAPC is non-mandated, so they're just doing it because they want to keep track, they want to do a surveillance for their own hospital, but the CODI is mandatory. So I just want to highlight that, because you can use this slide as a resource. And then the bottom part of the monthly reporting plan, you will see for MRSA and C. diff, at the top of the slide, you'll see FAC-wide in for MRSA, which is for the blood, and that's for the entire acute care facility. But again, you're going to subtract out the admissions and patient days from your IRF from this FAC-wide in for the entire acute care facility. You also see a FAC-wide in for C. diff. You see the ED outpatient MRSA as well as C. diff. And then finally at the bottom you see the rehab that, again, two separate lines, one for the C. diff and one for the MRSA. So I wanted to give you an example of what your monthly reporting plan starting from January 2015 to the present year and month. This is what it should be looking like on your monthly reporting plan. If not, you have some resources now to review, and you can always give one of us a call if you have any questions. Moving on to the next facility that has a deadline of February 15th. And this is your LTAC, your long-term acute care hospital. Oh, I apologize. Morgan's computer died, so our screens I'm no longer looking at the screen, so I thought the entire region went black. I apologize. Okay, so this is about the LTACs, the long-term care, acute care hospitals, and their deadline has also been extended. I should have put another unbelievable here too. So in the past, the LTACs had 45 days from the close of the month to put their NHSN data in. That was a pilot that NHSN and CMS did together. CMS has decided that it really, I guess it didn't pan out. So now they are going to have, the LTACs are going to have the exact same reporting period as the acute care hospitals, 4.5 months from the close of a quarter. So for February 15th, 2016, they will have to make sure their data is in for quarter 1, quarter 2, and quarter 3 of 2015 for their CLAPC, their CODI, their MRSA, and CDI lab ID event. So again, CMS hears us when we do have issues, and it's good that we keep them informed of all the barriers that are in place. And so they've heard the LTACs, and they have extended this deadline. Okay, the top of page 13 of your newsletter talks about NHSN Accessibility. I can't stress this enough to every single hospital, LTAC, nursing home, who's ever listening. There's got to be more than one person that has NHSN Accessibility. Now, you can only have one point person, one administrator per facility, but there could be several data users of NHSN that can have administrator rights, that can have access to all the data, to data submission, to report generation, and that is so important. And we here in Connecticut, I work very closely with our DPH. We say it together all the time. If you know you're going on vacation, or extended vacation, or if you know that you're leaving your position, please, before you leave, turn that administrator role over to somebody else in NHSN. I can't stress it enough, and each of the HAI state task groups also can't stress it enough. So please, 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 because it just takes so long to get another SAMS card up and running for your facility, and you have to re-enroll, and it just takes time away from the work that needs to get done. So that's that section. And then I'm just going to touch a little bit on the long-term care facility components. Now, this is different from the LTAC. The LTAC was a long-term care, acute care hospital, long-term acute care hospital. This is the long-term care facilities, which are the nursing homes. I just wanted to let the acute care hospitals know that the QIN-QIOs around the nation will be receiving a contract modification from CMS to begin working with the nursing homes to enter C. difficile lab ID events into NHSN. And this is going to occur this year, very, very soon. We're just waiting for the contract mod to get into our hands. There's going to be some live training at the CDC concerning this new work, as well as there's training going on right now for the QIN-QIOs to make sure that we're all very comfortable on how to enroll new facilities into NHSN. The goal of this new project is to recruit at least 15% of the nursing homes to enroll into NHSN and then to sustain CDI reporting for the duration of the project. But it's not just about data entry. It's also about decreasing their C. difficile rates. So we're going to be, we as the QIN-QIOs will be working closely with our nursing home colleagues to run trainings for both hospitals and nursing homes so we can improve the communications between these facilities when there is an active case of C. difficile. And so there's just better communication and better working environment between the facilities. So it's all good, but we just wanted to make sure that you were aware of this project coming down the pike. And also for the new long-term care facilities, the nursing homes that will be registering their facilities into NHSN, they're going to have to do the annual facility survey. Or if there's nursing homes out there who are listening and that you have been putting data into NHSN, you have to remember you have to do the annual facility survey like the acute care hospitals do and the long-term. The LTAC also has to do and inpatient site facilities as well as the inpatient rehab facilities. And the data that's to be submitted covers all of 2015, January 1st, 2015 to December 31st, 2015. With that, we're taking a pause. That was a lot of information we just covered. Okay, since Morgan has lost her ability she's back, so she has missed whether there were any questions into chat. If you would like to ask a question or if you have a best practice or a tip of a best practice on keeping your data current or submitting data into NHSN that you would like to share with your colleagues throughout the New England region, please hit #6 to unmute your line. We'd love to hear from you.
This is Julie Jefferson at Rhode Island Hospital. Are you sending out copies of the slides?
Yes, that came out with the webinar invite that you should have received that told you how to log on to the webinar this afternoon, but we will repost that so you can get copies of the slides.
Thank you.
It's in chat right now.
Well, I'm not seeing chat.
Oh, okay. But also, you know what we can do? Yep. Okay. We have a question about what are critical access hospitals expected to report. That is a great question. And because I live in Connecticut, we don't have any. So I'm going to turn this over to Margaret because we've had this discussion in our internal meetings just last week. Margaret, if you can unmute yourself, I'm going to sort of throw it at you.
Yes, I have unmuted. And the main thing right now for critical access hospital reporting is in the employee or healthcare personnel module. which is an influenza vaccine. Now remember that a lot of the critical access hospitals in all of the northern tier states, where they primarily are located, Maine, New Hampshire, Vermont, have state reporting requirements that are very specific to their state. However, in terms of the federal requirements or CMS requirements, right now it's healthcare personnel reporting of influenza vaccine. Unless I'm missing something here, I don't believe I am. That's it.
Thank you, Margaret. Forgot your name. That was a great question. And again, the critical access hospitals are the backbone to the work of the healthcare in New England. So it's a very important healthcare facility. So the more information, the data that you can submit into NHSN, the better for all of us. But as Margaret says, as of right now, for the federal reporting program, there are no mandatory reporting. Any other questions?
Margaret, I just wanted to clarify that is a federal requirement that they.
Oh, it is federal.
Yes.
Thank you. Thank you so much, Margaret. I didn't realize. I thought it was a state requirement. Thank you.
Mm-hmm.
I was thinking of IQR. Thank you.
Yeah, no, how do I get it to,
Okay, if you could *6 yourself to make sure that we're muted for the next session. Oh, okay, we have one more question. Back on slide 21. Let me go back. 21, okay. You showed the reporting plan for IRF. MRSA has all specimens. Isn't it blood only? No, that was, yes, you're absolutely right. So this hospital, thank you very much. You're absolutely right. It should be blood specimens. Unless they are surveilling all specimens for MRSA. But CMS will only take blood specimens from their pool of lab ID events. But you're absolutely right. Thank you very much. Most hospitals will have blood specimens only, so thank you.
Carol, they will have to change that to lab ID event blood specimens only. That was a good catch.
Thank you very much. I'll get back to this hospital. Okay, and one last question. In Maine, critical access hospitals are required to put in lab ID MRSA and lab ID CDIF per state regulations. Thank you. Okay, that's important to know. Again, we're talking at a high level, we're talking federal level, so it's good to know, it's good to share this information about state information. So thank you so much from Maine, Anne-Marie from Maine. Okay. I am now going to turn this back over to Denise, who's going to be talking about dialysis component of the NHSN newsletter.
Hello, everybody. The dialysis hasn't changed all that much. There's a little bit of a difference on the annual survey. The event form has been updated, and if an IV antimicrobial starts is selected, there's some more questions that come out behind that. And there's some questions regarding the risk factors. And it's also going to be possible to use CDA file format with this. But again, that takes a lot of ID work to get it done. And right now, everyone is IT hungry because they're going through conversions to different news systems. Epic is one, for example. And there's not a whole lot more I can tell you about the dialysis at this time. I'm really sorry. So I think I'll hand it over to Margaret.
Yeah, thanks. And I'm going to just move on to the next slide, which talks about specifically the biovigilance component. This is on page 16 of your newsletter. This is also referred to as the hemovigilance module, and it was really created for those of you who are not using it. My understanding is folks in Massachusetts use it to a large extent. This module was designed to focus on transfusion-associated adverse events so that we can improve patient safety by tracking transfusions. And this would include both blood products as well as man-made products that are blood components. So in 2016, there were changes to the module that affected several different parts of the input. And first of all, the denominator reporting now is becoming more refined so that it will include not only the number of units and aliquots, but also the type and collection methods that are used relating to a new technology called pathogen reduction technology. And there's going to be training materials coming out, so keep your eyes on that, and that should be out soon. In addition, in the annual survey, there's been a question added, and this relates to the fact that the individual units now are going to be described, and this has to do with platelet and cryoprecipitate products, so that there's not going to be pools, but rather individual units reported. And so there has been a question added to the annual survey about this. The good news is that clinical document architecture, or CDA, is being developed much like what you have the advantage of using for submitting denominated data for your SSIs or surgical site, all of your surgical site cases that you're tracking. And this will be an opportunity to upload your denominated data for the biovigilance component using a computer. So it's supposed to be hopefully a big breakthrough in terms of the speed and ease of transmission. And there was a reminder from NHSN finally to make sure that you complete your 2015 data in a timely manner. There was no date specifically mentioned, but they are asking people to close out 2015. And I'll turn this back. Thanks.
Thanks, Margaret. This is Carol again from Connecticut. And I just want to mention this is part of the newsletter about the NHSN training that's coming up at the CDC in Atlanta. The invitation came out about 3 weeks ago to all the NHSN users around the nation. And just last evening, several of the New England QIN-QIO task leads received the registration that they have. Their registration has been accepted. So look in your email. If you had applied to go to this in-person training, it starts on Monday, February 29th, and it goes to Friday, March 4th. It's at the CDC. And this is the annual training where the NHSN team works together to go over the new definition changes for 2016, also definitions and surveillance for device and procedure-associated infections. They also review the advanced NHSN analysis, and they also do some great case studies that really can help as you are doing your work during the day and you have a really interesting or really hard case to decide whether is this a CLAPSI, is this a CLAUDI. These case studies can help get your mind. Excuse me, please put yourself on mute, which is *6. Thank you. We're just going to go ahead and remute everyone.
Why are you going those days? Are you going back to Florida? Yeah. King, you know we have this training. Yeah.
Denise, you're not on mute, hon. Okay, for those of us who can't make the trip to Atlanta, and the CDC has stated that they are going to do some live streaming that's available for each of the sessions. That information will be coming out shortly. So I just want to do a shout out for Vermont. Our state task lead, Reggie, was talking just this morning at our regional weekly meeting that she's planning on doing a live streaming NHSN party for the week, because if you're like me, if I'm sitting at my desk alone watching 8 hours of NHSN training, I will start multitasking and not pay attention to this really important information. So if you are in a room with other colleagues that are in the same boat, that we all need this information, and you can network with each other during the breaks, and you can do a potluck. Everybody just brings something to have a nice little lunch with. It will make the day go by that much faster and much nicer. So Reggie Cooper from Vermont says that she's planning on letting the infection preventionist in her state know where her party is going to be. So be on the lookout. And I from what I hear, maybe Maine is going to be doing the same thing, but Danielle hasn't really committed to that yet. But so again, think even if you're not doing it with a QIN-QIO, having a party with a QIN-QIO, invite a couple of infection preventionists to your hospital, get a conference room for the day, and learn together, because it does go by that much quicker and that much better. And then finally, the last section is going to be Denise again.
Hi, everybody. I saw in the chat that you're all concerned about the CSV files and will they be accepted, won't they be accepted, and where can you get information? You can get information on the link on pages 17 and 18 page 18 for the CSV files. And the CDA file formats are very specific, and they have their own help desk line at nhsncda.cdc.gov. So the CDA files are definitely something that your vendor or your experienced IT will have to master. The CSV files, pretty much the biggest change to get the data accepted right now for SI denominators would be the header row and non-header row, and that's explained in depth on page 17 with a link to how to reorg your upload files. So nobody's really going to know that their files are broken until they go to upload January. So the sooner you can get this to your IT department, the better off you'll be, because you won't be delayed in getting your January forward data in. So I hope that answered everybody's questions about the CDA and CSV files. Everyone's going, what's a CDA file, what's a CSV file? CDA files are what they use to bring the data up through the lab and all of that. They can combine a lot of different pieces of information into one file. And the CSV file looks kind of like an Excel sheet with rows in very specific formats and header rows and non-header rows. And that goes into the system by an upload procedure that the NHSN user does. Does that help answer the question? And that's pretty much the end of what we had to offer you guys today. I'm going to open the lines for questions again.
Absolutely. Thank you so much, Denise. And so we have, so what is the best, this is from the chat box, what is the best resource or reference resource for IT departments to determine what data is needed for the denominator reporting for colon and hysterectomies? Again, those links that are part of that what Denise went over for SSI data, the ICD-10 PCS code and CPT codes, those links are very important. I would share those with your IT department. Denise and Margaret, do you have any other recommendations?
No, I'm trying to get to that page because I was tossing them aside as you did it. That is on those links are on pages, I believe it's page 3.
Yep, page 3.
So, those will help your IT department decide what codes go in and what go out for remapping and doing the hips, the colons, the knees, the hysterectomies. And it will just make it a whole lot easier if you can get this to them now. All of this was actually put out in the September newsletter, and nobody kind of saw it. So this is one of the things that we think is really important, as well as the other thing in September was the new healthcare worker personnel summary influenza data that's required for specific facilities, which is, I believe, inpatient psych is new this year, and end-stage renal disease, dialysis. So those are both worth looking at, too.
All right, thank you. The other question on chat would be, would you happen to know if we use an electronic upload of denominator data into NHSN and include data on the report for units not on the monthly reporting plan, will it still accept the data for those that are, or will the whole report be correct?
That, again, should accept it all. The reporting plan only specifies what will be sent to to CMS for the state. So you can upload, if you wanted to do additional surgeries that were going to be reported to the state as opposed to CMS, they could go on there. There's nothing else that wouldn't go because you're uploading surgeries. You're not uploading like units or anything else like that. So as long as you have the correct codes, they should go into NHSN.
Thank you, Denise.
You're welcome.
Okay, any other questions? We certainly hope you have found this helpful. We just know how busy each and every one of you are, and that we just felt that this was an important resource that many people just can't seem to find time to review. So we just wanted to do a high-level review. We wanted to make sure you knew what the resources that are out there, and we wanted to make sure that, especially when the inpatient rehab facilities, that you still have 2 weeks to go ahead and change your, to make your data accurate if you haven't put the data in correctly as of today. So this is a contact information of all of the HAI leads in each of our 6 states. And please, we're just a phone call away if you do have questions. And I'm going to turn the last bit of information over to Morgan.
All righty. Well, thank you guys for a great discussion, and we did have some good questions today, so that was wonderful to hear. A few announcements. As you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill it out today, or if you're sharing the computer with someone else, you will receive a follow-up email tomorrow with the link to the evaluation, as well as the link to our events page on our website, where all the documents discussed today can be found along with the PowerPoint presentation. So thank you guys, and have a wonderful rest of your day.
Bye, everyone. Thank you so much for sharing your hour with us. Have a great day.